oversees the company's health equity strategy and has responsibilities in the areas of corporate social responsibility, addressing social determinants of health, and public health surveillance. She currently serves as the clinical lead for Florida Blue's COVID-19 response. Dr. Wells is a graduate of Florida A&M University and the University of Florida College of Medicine. She was a National Health Service Corps scholar and completed her service commitment in Duval County as a county health department physician. Early in her medical career, Dr. Tice Wells became interested in addressing health disparities and delivering culturally competent care. Before joining Florida Blue in 2018, she spent 17 years as a public health physician, serving in numerous leadership roles, including that of County Health Director, Deputy Secretary for Health, statewide medical director for the Florida Department of Health, and chair of the state's Health Equity Program Council. Welcome, Dr. Wells.
Good evening, everyone. I am excited to have the chance to participate in our discussion tonight. I enjoyed the last event that was co-hosted this way and thought that not only was the conversation important and rich, I think the collaboration has such extraordinary value that I was delighted to have the opportunity to participate again. The other thing that makes this conversation special for me is that it feels very much like a conversation between family members. Those of us who are in healthcare, who have the opportunity to influence the choices that people make in order to achieve their highest level of health. Those of us who, since the start of the pandemic, have fielded numerous questions about the virus, the treatment, the symptoms, the vaccine. Those of us who haven't had many off days because we become the local expert, not just for our friends and families, but for our neighbors, for acquaintances. It is nice to have a conversation that is centered around us and our own concerns and strategies that we must put in place in order to do what is necessary to ensure that our communities rebound from the COVID-19 pandemic. Next slide. My comments today they're going to be brief. I think the value that this evening is going to bring is really going to be in the discussion with the esteemed panel. And in fact, most of the content that is specific to the vaccine and to your concerns and the concerns I'm sure you've heard about the vaccine will be left for that panel discussion. So I'm really going to very briefly, we'll talk about COVID. I want to really call out some impacts that COVID has had on the minority community. I want to alert us as a healthcare community to the potential long-term impacts of COVID-19. I'm going to talk briefly about prevention, and then we'll talk just a bit about what it is to be a healthcare professional and the COVID vaccine. Next slide. So coronavirus is caused by, this coronavirus disease is caused by virus SARS-CoV-2. It is a respiratory virus, and it is a member of a family of viruses that cause typically very mild respiratory illnesses. And in this case, we have found a member of this viral family that not only spreads very readily, but also causes more severe disease. in the last 11 months, we have seen a significant amount of improvement, not just in the care protocols related to COVID-19 management in the hospital setting. We've also seen some advances in the treatment. As we have tracked and trended our case rates, our hospitalization rates, and then our death rates, we find that overall hospital stays are decreasing, that we are able to manage more of these cases on an outpatient basis, and we are availing ourselves of the emerging clinical science in terms of the development of new medications. That said, we have had more than 26 million cases in the United States and more than 460,000 deaths. And if you think back with me to the start of last year, when in January we first got wind of something that was occurring overseas, and then the first cases identified in the state of Washington, and fast forward to March when the first cases were identified in our state, the impact and the implications of the impact of this disease on our communities is significant. And very early on, we recognized that the burdens of this disease were going to be borne more significantly and more heavily by communities of color. As our conversations have continued, we have watched this virus do what viruses do, and that is mutate. And so you've certainly heard about the variants that have begun to enter our communities. And in fact, it's thought because of the UK variant in particular, that there may actually be a condition where we'll see higher prevalence of some of these new strains than we will of the previous strains. That's concerning because certainly we worry about increased transmissibility, so it being more contagious, but also raises questions about the treatments and the vaccines, which we'll focus our discussions on this evening. The other thing that is of concern is that our testing positivity rate as a nation is still sitting right at 10%. While the number may not be of significance to you, the value of that particular metric should be. It is a way for us to gauge how much disease is still existing in our communities. And in fact, we saw a substantial surge in cases as folks traveled over the holidays and gathered over the winter holiday. And in fact, we have a few concerns about the impact of recent Super Bowl assemblies in our state in particular. Next slide. Now, very early on, it became evident that the impact on our communities was significant, because one of the first data points that emerged was that folks who had a diagnosis of diabetes seemed to do worse with COVID-19. And just as we were getting our arms around what that meant, certainly those of us who have done work in health disparities, and many of us who have taken care of minority populations, recognized that by and large, that would mean that there would be significant impact in the minority communities, because we know that disparities exist with chronic diseases in our communities, and certainly diabetes is one that tops the list. As we began to work to problem solve and to determine how to address that, I know at Florida Blue, one of the things we began to do very quickly was identify our members with that diagnosis and proactively do outreach in order to ensure that they had what was necessary to protect themselves. Did they have access to masks and hand sanitizer? Did they have need of any sort of support? Did they understand how to navigate a rapidly changing healthcare system? But as we began to gather this data, we very rapidly then noticed that the hospitalization rates and even subsequent death rates were higher in minority communities. And that is the challenge of this disease. And that is what prompted the call to action that those who were sponsoring this event answered some time ago. The concern going forward, though, is that as these impacts continue to run rampant in our communities, inequitable distribution of vaccine, as well as a higher prevalence of vaccine hesitancy in our communities, may actually cause those disparate impacts to persist. Next slide. And as we look forward, and I think it really is an important call out, right? We've talked about the disease impacts, right? We know that health disparities exist as it relates to diabetes, cancer, hypertension, and heart disease in the minority communities. We also know, though, that it is communities of color where there are these concentrated impacts of the barriers that actually promote and cause health disparities. And as a result, the pandemic itself and what was required of us in response, sheltering at home, moving to remote learning, isolating ourselves, restricting ourselves from those who were outside of our households, all of those action steps which were required themselves have an impact that we need to be cognizant of. In addition to that, we have to recognize that the stress that results from a disruption of lifestyle, concern about your own safety and health, a change in your environment, your routine, a loss of resources. There were significant numbers of folks who financially endured significantly increased strain because not only did they lose employment, but as a result of it, they lost healthcare coverage. All of these things are additive in their impact and are things that we need to think now about how we should monitor going forward. For example, children who moved into a remote learning setting, think about their ability then to progress academically appropriately. Many children found themselves without regular meals because their one source of regular meals was in the brick and mortar school setting. In fact, there were kids who were displaced from typical homes because they needed access to Wi-Fi and that wasn't present in the home, their primary home. All of those impacts are significant. We've had more loss in our communities, more death. We have seniors who have been isolated. We've had an increase in drug overuse and abuse, and in fact have had a significant increase in the number of overdoses since the pandemic began last year. These are things that won't necessarily make it on the radar unless we are advancing these concerns going forward. And I think the long-term impacts of things that are not yet measured, the increase in intimate partner violence, the increase in child abuse, all of those things are occurring, but they are not being reported. So we have to really be conscious of those impacts and be ready as a healthcare community to recognize them. That means train your staff, learn your community resources, be ready to make referrals and support care and intervention, but also understand that they may not readily be reported. Next slide. Now, what have we gotten good at, right? We are good at these health behaviors, right? We have incorporated into our routine the things that are necessary. We're watching our 3 W's, right? We're wearing our mask, we're watching our distance, and we're washing our hands. And I think we have learned anew how to accomplish the activities in our daily lives. We have learned to minimize our exposure and contact. Those of us who could not move to a remote work setting learned how to incorporate things that kept us safe during our work day. We have modified how we get our groceries. We have changed that, that whole Saturday runaround thing you used to do, right? As a mom, 16 stops, right? You have to narrow your circle, right? And so, we minimize our exposures by decreasing our activity and keeping our circle small. We've gotten good at that. I think we certainly have, and those are good things. But what else should we be doing? Next slide. And this is where you come in. Now, I opened our discussion this evening by saying that we are a part of a family. And because we are a part of a collective healthcare community, I can say that I know that many of you, like me, have become that expert in your family. My parents are 81. My mom is a retired nurse. They won't swallow a single dose of anything prescribed, right? The conversation is always, well, she told me to take thus and so, but I wanted to run it by you first, right? And I'm like, but Mom, they saw you, like she did the exam, We are the trusted advisor for many of our family members and our loved ones. And in fact, in some cases, I don't think we would have it any other way, right? Because we want to have the opportunity to inform the care of our loved ones. We want to be sure that they're getting the advice that they need. And those of us who understand that unconscious bias can often drive health disparities want to be certain that they're getting a fair shake. Right? I do the 20 questions with my family members. What did you tell them? What did they say? What did they say back? What is this? What are they treating with this? How long are you supposed to take it? When are you supposed to come back? Right? We become that. Now, as we shift into what I hope is recovery mode from the COVID-19 pandemic and start to talk about vaccines, we have to recognize that that role as trusted advisor, if anything, is expanded. And so it is important that we leverage all of the expertise and knowledge that we have access to in order to prepare ourselves for vaccine conversations. No longer will these conversations be limited to those of us who take care of pediatric patients, for instance, and have really honed the skills of educating parents and moving them toward having their children immunized. Now it becomes our collective responsibility to help really increase vaccine confidence in our communities. Next slide, please. Vaccines aren't new. They are not new, right? The difference between what we have all done in preparation for our children to go to school and what we have done in an effort to protect our loved ones, our seniors, this is not new. What is happening in this case is that the vaccine development and its distribution, including all of the information gathering and understanding and learning, all of that is happening on a stage. And that has really set the foundation for an amplification of existing mistrust, and it has prevented the clear and adequate messaging that would allow folks to make a really good informed decision. Again, I can tell you, I've got 4 children who have been fully immunized, and I can't remember a time when I thought through, wait, how was that vaccine made? What kind of vaccine is that, right? I have always asked side effects, concerns, that sort of thing, but I have never been so fundamentally involved in the construct of something like a vaccine. You trust the experts. And we now have really got to develop our expertise. Advance 2 slides, if you would. Here's the reason that this conversation is hard, right? We've seen graphics, tons of graphics like this, and it becomes very difficult to make sense of it. I didn't want to horrify my co-panelists, but I have one that has every type of vaccine and how it's made and how it generates the antibodies and that sort of thing. And it's spaghetti on a slide. To use resources like this to try to create clarity around something that is impacting our community so significantly becomes significantly challenging. I'm not going to stay here, but I simply want to use this visual as the foundation for the conversations that we must have. And we have to agree that we may not settle it this evening. This may be an introductory conversation where we establish appropriate rapport, where we lay some foundational information, but we acknowledged it, and our panelists in our prep discussion did acknowledge this, that it is probably wise that this be a series of discussions so that we have the opportunity for folks to synthesize some of this information. You're going to hear a lot of expert information shared in our panel discussion, that we allow that information to be synthesized by those who are participating this evening, and then return to sort of collectively respond to the concerns that may remain. Back up 1 slide for me, please. And here's the other thing. Now, when we talk about health disparities, you know, there are national goals that have been established to try to create equity, you know, to reduce the disparity gaps that we know exist in the chronic disease realm. And you know, almost as soon as I recognized the potential impact that COVID was going to have because of chronic disease health disparities, I had a similar concern that we as a medical community needed to urgently work, not only to get information in the hands of our minority community members in terms of how to protect themselves, where to go for treatment, how to engage their physician, how to stay engaged in care so that they didn't miss the opportunity to get preventive services and those sorts of things. Just as urgently, I began to learn about vaccine development, because my concern, and I think it's shared by many of my colleagues who are participating this evening, once the vaccine is rolled out to a significant extent, the disparity in distribution, if it leaves communities of color behind, and the majority of the majority population is vaccinated, this will not be the newsworthy issue that it is found to be today. And my worry is that if we as a community don't figure out how to increase vaccine confidence in our community, and as a result, get more shots in arms, get more people protected in our communities, that the disparate impacts to our communities will persist long after recovery occurs in majority communities. That, to me, is the call to action that is so significant at this moment. Advance 2 slides for me. What's the bottom line? So, you know, I wanted to say something really hip, and I thought it was, I think the fact that I'm saying that I wanted to say something hip says that I'm not hip. But I thought it a critical, a key component to this conversation and to this messaging is for us to really engage together around a simple message, right? One is you have the opportunity to do your part, right? Being vaccinated, you yourself being vaccinated, not only does it demonstrate something to those who are watching you and for whom you are the trusted advisor, it also protects you. So in terms of your risk of disease, of severe disease, having that risk be minimized, right? And the value that has in terms of your ability to continue doing the great work that you're doing in your community, right, is tremendous. And so, you know, everyone should feel like they have a part in the solution by being vaccinated themselves. But the other thing is, this is our shot. This is our shot. This is our opportunity to turn the tide in our own communities. This is our ability to leverage something that will allow us to re-engage. I haven't seen my parents since late spring. They're 81. They've lost friends in the last several months. This is our shot to move toward normal. This is our shot to decrease our stress level and our fear and our concern about our loved ones. It's our ability to resolve some of the isolation that is impacting the health of many of our community members. This is our shot to move our communities toward better financial health. This is our shot to get folks comfortable returning to healthcare. More than 40% of folks report that they have delayed or canceled care because of COVID. We've got to get folks plugged back in, because that is the stuff that cancers are made of down the road. Missing screenings, missing mammograms, not having your colonoscopy. This is our shot. And so I hope in our subsequent discussion that you will get to the point where you are, you feel knowledgeable about the vaccines, number one. Number two, you feel a connection to the community responsibility that exists for all of us who are part of this healthcare community. And number three, that you recognize your opportunity, your shot to protect yourself, demonstrate for others the value of protecting yourself, and move us and our communities toward normal. Thank you for your time and attention, and I'm looking forward to the remaining discussion.
Thank you, Dr. Wells, as usual, for giving us great information. I'd like to ask our co-hosts, and before I forget, let me acknowledge some more folks. We are excited to also have as a partner this evening, FAMU School of Pharmacy, and that is Florida A&M University School of Pharmacy, as well as some wonderful students that are interning with the Jacksonville Urban League who are serving as our co-facilitators this evening. So I would like to ask our facilitators, Catherine and Erica, are there any questions from the chat room for Dr. Wells at this point? If there aren't any questions, I would like to ask Dr. Rogers Kane to join us in the discussion. And Dr. Kane, I think you may have a couple of questions for Dr. Wells. Let me first introduce Dr. Rogers Kane. He has been in private practice as a family practice physician in North Jacksonville for over 30 years. Dr. Kane graduated from FAMU School of Pharmacy and was in the first class of the Morehouse School of Medicine. He was the chief resident of UF Health Jacksonville in 1988. He is the president of the Northeast Florida Medical Society Foundation and president emerita of the Northeast Florida Medical Society. Dr. Kane is a graduate of Leadership Jacksonville, class of 1995, and Leadership Florida, class of 1996. Dr. Kane, did you have any questions for Dr. Wells at this time? Unmute Dr. Kane, please. Excuse me, that's FAMU College of Pharmacy and Pharmaceutical Services. Pardon me. Go ahead, Dr. Kane.
Yeah, I wanted to be sure that you acknowledge my old alma mater and that they are critical partners with the rest of our partners in terms of how we're attempting to reach the community. What I have, the question I had with, and thank you for the introduction, by the way. The question I have for Kelli, one part is a statement, and the other part is a question. Um, um, the when you're talking about the professionals, health professionals doing their job, you're also including anyone that was that has degree in a health science and may also be considered by the family as being their expert, whether they're physicians or not. Is that the thought that you had behind it? Unmute Dr. Tice Wells, please.
Absolutely, yes. Yeah, I think that there's a role that we all play, and I was very intentional in my opening remarks when I called us all family. We're all a part of the care continuum, and particularly for our family members. I think you leverage the resources that are available to you. So we have not just pharmacist team members, but pharmacy techs. There are help those who are involved in the health field who have worked for years in the long-term care facility setting, for instance, as care aides and care technicians, and those that are on the road to nursing degrees, but stopped and got an interim certification. All of those folks are a part of this conversation, and in fact drive a lot of the decision making of our community members.
Okay. The second question I had, that slide was striking in terms of the degree that minorities were being affected, including the death, the morbidity and mortality, the death and the sickness associated with it, and the degree at which there was such lack of vaccination by these same people, same minorities or people of color, being the one who are so much less receiving the vaccine. I think the majority was receiving a majority of the vaccine, 75% of it. One of my question is, I saw particularly with the Hispanic community, how they were so affected, and we both know that it's not because of the color of the skin, that it is probably because of their job status and them being essential workers. Would it better serve us at some point in time that we, regardless of age, that we vaccinate those essential workers? We're not just talking healthcare workers, but those essential workers who doesn't have the privilege or the capability of staying at home and working from behind a computer screen like you and me and some of the others on this call, but they have to go to work. What's your thought on that?
I think that is a very important call out. And in fact, as the CDC works to identify the phases of vaccine rollout, their definition of high risk and the nod toward health equity, I don't think the focus on communities of color was amplified to the degree that it should be. And I think those of us who have done this work will agree that often the decision makers feel that the solution meets the need. And those of us who have done this recognize, no, because folks can't get over there, right? They can't get over there, right? We immediately we knew, right? With, if you select this retail chain versus that retail chain, you've effectively limited access. We went through the very same thing, right, with COVID-19 testing, right? Where you choose to offer the testing. And for me, the testing piece was so critical because you have to test in order for folks to understand what they need to do in terms of isolation and quarantine. So limiting access to testing in a community of folks who were still working and still, having high risk exposures was really tantamount to facilitating spread. And so the case can absolutely be made that as you look at distribution and rollout, that you quantify risk based on the data you now have around disease impact, and you balance it, right? Equity work is leveling the playing field so that everyone has the same opportunity, right? In terms of disease and disparate impacts, right? 65 may not be the threshold of risk for someone who is a part of a community of color. So I really do appreciate that call out.
One last thing, and I'll be finished. So when you sit back and one of the things that I think we did a tremendous failure at is contact tracing and following the virus. We failed miserably at that, especially in the state of Florida. I've seen such a great job done in DC, but in the state of Florida, it was miserable. And so is it your opinion or your concern that part of the reason that we have such a failure in terms of vaccinating the most vaccinating equitably the community most at risk, is that related to that contact tracing failure?
Well, I think the difficulty with contact tracing in our state is a symptom of an infrastructure problem that exists in our state, right? Because there isn't an agency, an entity, an organization that can accomplish that alone. That does not exist. In order to do it successfully, you have to be able to collaborate. When you have a structure that, for instance, separates or isolates the public health experts or puts them in a position of being under-resourced, and you have maybe executive actions that are designed for exposure and mainstream attention versus true solutions, then you get what the system does, what it's intended to do, right? If you look, if you look under the hood a bit, the places that have been able to do contact tracing better are the places where there is local collaboration between public and private entities, the payer community, the healthcare community, because everyone can contribute, right? There are some businesses, for instance, who had significantly reduced business operations, and so had call center staff, that could have supported contact tracing, for instance. There were states that could leverage funds in a way that we just weren't successful doing here in the state of Florida to immediately stand up phone systems and computer systems and those sorts of things, you know, and we were really working on a very under-resourced and antiquated infrastructure that really couldn't support what a pandemic required, right? And so, you know, and it's one of those lessons learned, having been a health officer, I can tell you, you know, you look around and you see that it's broken, right? But you can't fix it in flight, because it really is, you know, it's the work that you're doing from a population management perspective to build an infrastructure and then call out the gaps that exist. We can't run around with an underfunded Department of Health. You can't do that, right? We have to be able to collaborate. You know, we have to, you know, yes, there's a task force, I'm told, but who gets to come?
Right.
And who's informing those decisions? And that basic structure and approach to problem solving varies community to community, but it really it varies because we don't collaborate very well. And so that's the first problem to solve.
Well, I thank you very much for answering that question. Jocelyn, I'm turning it back over to you. Thank you, Kelli.
Thank you, Dr. Kane, and thank you, Dr. Wells. Very enlightening discussion. Now we're going to move on and with our panel discussion, where we have a distinguished panel of individuals who I am happy to bring to the discussion. And I hope that from the questions that will be posed to the panelists, you will gain a better insight as to why we are hosting this event tonight. First, I'd like to bring, and Dr. Kane, you are joining us as a panelist, so stay tuned. I'd like to bring Dr. Kim Barbell Johnson to the discussion. Dr. Johnson is a Mayo Clinic Jacksonville residency-trained family physician. She has served in various leadership roles in community organizations and academic medicine over the past 25 years of her medical career. She currently serves as the Senior Physician Investigator and Medical Trials Director for Clinical Care at Care Partners Clinical Research, a division of Family Care Partners. She has been the principal investigator for more than 70 clinical trials, including vaccine trials. She has been a consultant to the biopharma industry on matters of sickle cell disease and chronic disease education, diversity in clinical trials, and community engagement. Dr. Barbell Johnson currently leads the occupational health and COVID-19 workplace exposure risk mitigation efforts for nearly 300 employees at Family Care Partners. Welcome, Dr. Barbell Johnson.
Thank you very much.
I'd also like to introduce you to another Jocelyn Spates. Dr. Spates is a professor of pharmacy practice and the Associate Dean of Clinical Affairs at Florida A&M University College of Pharmacy and Pharmaceutical Sciences Institute of Public Health. She received her Bachelor of Science degree in pharmacy from Florida A&M University and a Doctor of Pharmacy degree from Idaho State University. Dr. Spates is an American Association of Colleges of Pharmacy Academic Leadership Fellow and a board-certified pharmacotherapy specialist. She is a member of several pharmacy organizations to include AACP, ASHP, and FSHP. She has also published numerous articles in peer-reviewed journals. And she wanted me to make sure I said she is a member of Alpha Kappa Alpha Sorority Incorporated. Welcome, Dr. Spates.
Thank you.
Next, I'd like to introduce you to Dr. Janitra Moore. Dr. Moore is a certified registered nurse anesthetist with a total of 12 years of nursing experience, currently working for Envision Physician Services in Jacksonville, Florida, and is the owner of Royalty Anesthesia Services. Dr. Moore was appointed clinical coordinator at St. Vincent Riverside for the University of North Florida Nurse Anesthetist Program. She serves as a board member of the Diversity CRNA Mentorship Program and First Coast Black Nurses Association as the second vice president. Also, Dr. Moore is the co-chair of the Diversity, Equity, and Inclusion Task Force for the Florida Association of Nurse Anesthetists. Also served as a sergeant of the United States Army of 8 years. Thank you for your service. And a cadre of 4 Georgia National Guard Youth Challenge for 4 years, teaching life skills to teenagers between the ages of 16 to 19. Welcome, Dr. Moore.
Good evening, everyone.
Lastly, I'd like to introduce you to Pearl Young. Ms. Young is a nurse manager for neurosciences and stroke at Baptist Health, Jacksonville. Ms. Young has been a nurse for 20 years with 6 years in nursing education and now 4 years in nursing leadership. She is dedicated to providing evidence-based and compassionate care. She is a member of the American Association of Neuroscience Nurses and has been recognized as one of the great 100 nurses of Northeast Florida class of 2019. She is the former president of the First Coast Black Nurses Association. Welcome, Ms. Young.
Good evening. Thank you for having me.
Thank you all for joining us on the panel this evening. Now we're going to go ahead and get started. And I'd like to remind our guests to please post your questions in the chat box because we will be answering those questions, our panelists will, at the end of the question and answer for them. I'd like to get started by asking each of our panelists, what are each one of you seeing in your community or where you work as it relates to the aggressiveness or severity of this virus? I'll start with Dr. Barbell Johnson.
Thank you. I can unmute myself. I needed the technical team to do that, so I was just waiting. Good evening, everyone. Unlike most of the panel who are clinicians, I actually work in a very specific space in clinical trials and in clinical research. Before this pandemic, it was basically 90% of what I did. Since the pandemic, what I've seen is what we're seeing in the clinic, in our family medicine clinic, and how it's impacting our employees. So my personal perspective relates specifically to the monitoring that I do within the corporation that I work for, looking at the family external exposure outside of the workplace, the COVID risk inside of the workplace, and the patterns that we've seen. I think what we're seeing in Jacksonville parallels what we're seeing on CNN or in MSNBC and other news venues, where we're seeing the impact of a virus that has not gone away. We're seeing the impact of what happens when we're not judicious about our protocols. We're seeing the impact of what's happening in communities when we're not unmasking, when we're not physically distancing, when we're not using the hygiene that we're supposed to. And we will see the peaks and the valleys because of those things. So I'm seeing that as it impacts our numbers. What I'm also seeing is the same fatigue that we're seeing outside of the walls of medicine, the very exhausted medical professionals. Many of you on this call are among those who have been working in this space for a year, just really trying to turn the tide. And while we are hopeful with the tools that we have in our toolbox that are being emergency use approved on the daily, we are still tired. And so the social and the biological and the physiological things that I see as a researcher come first to mind, but I'm sure as others answer this question, they can tell you more about what they're seeing with regards to COVID-19 and the pandemic numbers themselves.
Thank you. Dr. Spates?
Yes, on the academic side at Florida A&M University, we are seeing small numbers, again, because most of our learners are not on the campus right now. We did open it up to allow them the option to come back face-to-face or to continue virtually. And many of them have chosen to remain remote. And that is because of the numbers that we're currently seeing, globally. They have made that decision to remain remote. One of the challenges that we are facing, though, is that the learning is not the same in the remote setting as it would be face-to-face. So a lot of our learners are struggling in this environment. So we are continually working to try to make sure that we have processes in place to make sure they still get the best education that they can, even in this environment.
Thank you. Dr. Moore? Is she unmuted? Dr. Moore?
I think I'm unmuted now.
Okay.
In the beginning of the pandemic, for our services, especially anesthesia services, and being in the inside of the hospital, watching these patients come in, it was relatively difficult because we were scrambling, trying to find ways of how to take care of these patients and what we needed to do to take care of ourselves. The way we had to approach these patients, to what we had to put on in order to protect ourselves, the way we had to rush to the ER, to the ICUs, to help with airway management, from even discussing changing our ventilators to help these patients because we were running out of ventilators at the time. This affected the families. It affected patient care. It affected us. And even to present day, it's not as bad because we got got better information now of how to take care of the patients and the patient population. And, but still you see the fatigue, we're tired, we're burnt out, and it continues. But it's getting better. The more information being put out, the better it's getting. It's still very high risk for the surgeries and doing surgeries with these patients, but we can't not give patient care. So you can see the effects from the beginning until now. It has been very hard on the inside for us.
Thank you. Ms. Young?
I would totally agree with the other panelists. And then speaking from the stroke aspect of it, at the beginning, we really saw that patients were not coming in. So they were coming in further along in the stroke process because they didn't want to come to the hospital. So that was very hard at the beginning because patients that may have been able to get treatment earlier were not coming to the hospitals. And then as a nurse manager on the floor, definitely the visitation. That has been the hardest thing, is having to, deny 2 visitors because we only had 1 visitor at the time rule. So those are the things that have been specific to my area. And then also my team is tired. They're exhausted, but they are doing it every day. And so we're just so proud of everybody that's helping to fight this.
And I'll add, I'm proud of you as well. Dr. Kane? Unmute Dr. Kane, please.
Okay, well, I concur with all the panels that we have presented thus far. I really commend those ladies who are working in that hospital and putting themselves at risk with highly infectious patients and circumstances. What I've seen in the community is a lot of families being affected. I've seen where, the virus has come along and affected many families, the whole family at one time. I think about one of the families I've had was the mom, dad, and daughter, all 3 in the hospital on vents or on ventilators because they were all sick, and that COVID made them very, very. I was surprised that all of them made it out, and I was happy that all of them made it out. But and I've also seen where on a daily basis, I'm getting calls from patients. I'm COVID positive. What do I do next? And the answer is very hard, even though we have some improved treatment for them. It still is just so many that are calling into my practice, and my practice is not as big as many of the other practices around town, but it's significant. Actually, death has occurred in quite a few of my patients, and the illness that has occurred in quite a few of the patients. I had one day where I really just was mind boggled. I saw 16 patients. It was a slow day, but 8 of them were all about being COVID positive. And you just throw your hands up and wonder, why is this continuing if people are really protecting themselves like they should? And I'd have to go back to one of the earlier statements that Dr. Tice Wells and myself discussed, and that is that we have quite a few of those essential workers out there working, and they're in a multi-generational household, and they're bringing it back to their parents and their grandparents, and the people who least need to be exposed and affected by this virus, because they may not have the immune system to combat it. And you know, sometimes you have an overactive immune system, but it's like the young lady is saying, you're getting tired, you're fatigued, you're tired of watching families suffer, and they don't get a chance to see their loved ones before they die. They die alone, except for those nurses who are brave enough to stand in there and hold their hands. And it's so sad, you know, and so stressful to them.
Thank you. And you can, to our guests, you can see that our panelists each work in different settings. There's some obvious overlap. So we can imagine what not only their lives are like for those of you who are on the front line or behind the scene, but still come in contact or have some type of influence on patient care. So thank you. I feel like I should say to you, as we say to people who serve in the military, thank you for your service. So Now we're going to move on to talk about some vaccine myths. Dr. Johnson, I'm going to go ahead and give you a heads up to say unmute your line. How do we know if the vaccine is safe?
So let me just kind of give you a heads up that on our side as panelists, we can't do anything with the unmute button. So we're depending on the technical team in the background to unmute us. So the delay is not us not knowing how to unmute. We're just waiting for someone to unmute us. So
thank you. Sorry about that.
To let you know. But thank you for the heads up. That's an interesting question. How do we know if the vaccines are safe? And as a researcher, so let me give you a little bit of background about my job. I've been a family physician for a couple decades plus. About 10 years ago, based on my intellectual curiosity and wanting to know more about what I was doing with my patients, I found myself more and more interested in the trials that were happening to develop the medications that I was prescribing to my patients. 12 years later, here I am full-time in clinical research, completely immersed in clinical trials and data, mostly in partnership with the pharmaceutical industry and the biopharma industry, but also, as you heard in my bio, looking at academic research and partnerships with groups like the National Kidney Foundation and others to really just make sure that we are represented before information that guides our guidelines are produced. With that, the easy answer to how do I know that they're safe? Well, I speak research. I look at data every day. And so as I look at data, I can look for the things that should suggest safety. How do we do that in clinical trials? In clinical trials, in order to go through the very judicious and arduous process of bringing an investigational product to market, there are multiple steps. We'll talk about those probably a little bit in a little while. But when those steps are done, as part of that process, we must look at something called efficacy and something called safety. In looking at efficacy, we look at, does it do what it's supposed to do? In looking at safety, we look at things like, does it cause any what we call adverse effects? Does this drug cause any things that is the risk greater than the benefit? Are there things that we weren't expecting that we see? So in looking at the trials in the vaccine space, and specifically for COVID-19, and more specifically, the data that has brought these two emergency use authorized vaccines to market. In looking at that data, I have seen no evidence that has been concerning where safety is concerned. I have seen the same rigorous process for evaluating safety. I have looked at the documentation provided by the patients in the studies and those by those who have looked through a process called, arbitration, so to speak, and what they have reported. I've looked not because I'm part of those studies like some of my clinicians here in our community, but because I have sat with the data as it's been published in journals. And then on December 10th and December 17th, when the FDA allowed the public to sit in virtually in the process of the advisory board committee, I've looked at the data as it was being discussed with the panel of experts. And from that, and after that, actually, I actually felt most safe in concluding, or most confident in concluding, that the safety data was pretty much above board. What we know is what we know. The caveat, though, is that what we have evaluated is called interval data. And not ever before, actually, in my clinical trial experience, have we actually used exclusive interval data to look at safety. So we use data from a very early part of the study to look at safety, and these trials are still continuing. And while this is a long-winded way of saying, responding to the question, I think it's important to understand, one, that the trials are continuing. So where safety is concerned, there's still more information that we need to have. Based on the information that we have from the trials, based on other trials using these products or these platforms, based on animal data, based on trials that preceded the COVID-19 trials, based on the safety data together, I think that is probably the best way that I can assure you that I feel that the safety data is trustable and reliable. But I, again, caution us that there's more to come. We are continuing to monitor patients, both in the trials and our citizens around the world, as we vaccinate with the vaccines in the trials. So we are continuing to build upon this information, and based on what we have right now, I feel that the safety data is very sound, and the things that we are learning, the things that we are learning as we vaccinate citizens of the community, we're pretty much transparent as a medical community with those things. As you know, we've seen things that we did not see in trials, like allergies and anaphylactic type responses, and we've made recommendations on how to manage those. So I think that this is one of those times in medicine that the transparency of the process is really helping us to really trust the safety data.
Dr. Spates, is there anything else you'd like? Thank you, Dr. Johnson. Is there anything you'd like to add to that?
I think she did a great job summing
Thank you. And a lot of people wonder, Dr. Spates, why do I have to get 2 vaccines versus 1? Now, we know that there's a difference between some vaccines that are currently on the market versus some that are coming out. But some people just don't really understand. Is there anything you can speak to that, why there are 2 vaccines versus 1? Dr.
Really,
Spates?
it has to do with the efficacy and what it demonstrated in the clinical trials. So initially, when the 1 injection was given, there was some effectiveness in regards to reducing COVID transmission as well as COVID symptoms. So, but it was about 50%. And those investigators wanted a higher response than that. And so therein lies the reason why there are 2 injections of both of the currently available products on the market right now. Both of them have about 95% efficacy. And so that's what they were targeting. So those numbers are very promising. They wanted to make sure that the product that they were putting on the market would be able to prevent severe COVID in a nutshell, and to prevent symptomatic COVID as well.
Thank you. Dr. Johnson, I'm going to come back to you for a brief answer. Is it better to get natural immunity to COVID-19 rather than immunity from a vaccine?
And you want a brief answer to that one? Okay.
Of course I do.
The shortest answer is we don't know. What we do know is we know how our patients have fared who have gotten COVID and we have measured the immune response, their T cell response, their antibody response. We've seen the number of cells that they have in certain trials. We are hoping that that represents the responsiveness of those cells should they see the virus again. But reinfection is very rare. So we have a theoretical concept that what we know is what we know from natural immunity. The benefit about vaccination is that we can look in vaccine trials to look at what the body does when you're vaccinated to see if it parallels what happens in nature. So we can see if you're mounting the same response as those who actually got the disease. In these studies, the response was very rigorous. The response was appropriate. What we don't know yet, simply because of time, is this response sustainable? So we don't know both for those who have gotten COVID-19, the disease, nor for those who have been vaccinated, exactly how long, how durable will this response be? So you need to have the cells, but you need to have the cells do what it's supposed to do, what they're supposed to do when they're supposed to do it. And that's going to be the test of time. That said, and I don't want to be long-winded, we have some background studies that suggest that most of what we're seeing, particularly in the vaccine space, that response, we have seen enough trials to suggest that response is better than the 90 days that we're currently talking about. We're probably like 99 months in terms of a vaccine response to the full vaccination of the products using the mRNA platform. And so that's very encouraging. However, as a researcher, data is very important. So if the trials are actually based on 2 vaccines and we need to have those 2 vaccines for full complement immunity, essentially we should follow those recommendations as much as we observe what's happening after vaccination and put the story together later down. So we don't know, but it's hopeful that maybe they're equivocal, but we are very confident in the predictability of the vaccination that the response that we're getting to vaccination. So that's it.
Thank you, Dr. Johnson. So Dr. Spates, this question is for you. So yes, you're already muted. What's the difference between, and I think Dr. Johnson talked about it, or one of you talked about it a few minutes ago, what's the difference between emergency use authorization versus normal approval of a vaccine?
So the emergency use authorization is a process that's used to facilitate the availability of a medication in a public emergency. And so I'm sure we would all agree that this COVID pandemic is a public emergency. So we needed to get something out there to treat and to help decrease the deaths that are occurring with the COVID-19 disease. So we had to do an emergency authorization. Normally, under normal circumstances, a phase 3 study lasts from about 1 to 4 years. And that's usually an average. So in the phase 3 studies, you're looking at efficacy and you're still looking at safety. So you want to make sure the drug that you're using in the human population is safe and also it is effective. So that was where the Pfizer as well as the Moderna were approved in the phase 3 trials. They are still currently in phase 3. So data is still being collected for those 2 vaccines in terms of safety and still efficacy. As Dr. Johnson communicated, we're still trying to see how long the immunity lasts. But we needed to get something on the market and we needed to get something on the market quickly. And that was the reason for the emergency use authorization.
And I think that discussion, what you just made, is so relative that everybody wants to know, for those persons who are, a little concerned about whether or not the vaccine is safe. So the fact that the biggest thing that I got from that is it's a pandemic, it's a public health emergency, and we needed to act fast. And that's why that authorization is in process. And Dr. Spates, I'd like to follow up with another question. Is the live virus that causes COVID-19 currently in the vaccines that are being given in the United States?
No, ma'am, it is not. It is not a live, is not live COVID. It is actually messenger RNA. And you've heard that mRNA technology spoken about. So all it is it is injected and it tells your body to make a small part of the COVID virus, which is called the spike protein. That spike protein is what your body uses to mount an immune response against COVID. And so as you are getting those symptoms that you probably heard a lot of people talk about, especially after the second dose, some people are getting fever, chills, body aches. That's your body mounting an immune response. And so that is very common. And so that is pretty much what the messenger RNA vaccine does. And once your body develops the spike protein, that instruction or that messenger RNA is removed from your body. And now you have built up an immunity against the COVID virus. So it is not a live virus. And you cannot get COVID from taking the vaccine, which is also a myth.
Yes, indeed. Thank you. Yet another very important point to mention. Dr. Johnson, so people want to know who's been involved in clinical trials. Can you talk about who was involved or who's been tested, or were all populations tested when as the vaccine was being developed?
Yeah, this is it was advantageous for our community that Moderna and Pfizer both was very judicious in making sure that the enrollment in these trials represented those who were impacted by the community. That said, across the trials were different. Moderna was done exclusively in the United States. Pfizer was done internationally. So the data is representing two different populations because it's a pandemic. However, if you look at the United States data in particular, about 10% of the populations of both studies were self-described as African-American. About 25%, 23 to 25% were Hispanic in origin. So there was more diversity actually in these trials than we've seen in other trials for things that we use every day, from blood pressure medications to diabetes medications, some of the common things that affect minority populations of color. So in terms of the diversity, in terms of enrollment in these trials, there was significant efforts and actually successful enrollment of diversity. What that allowed us to see in the trials is do all populations respond about the same to this vaccine candidate? And in the trials, we saw that. We saw that independent of age, independent of ethnic background, independent of self-described race, and independent of any demographics that were reported to the FDA, that the vaccines performed about the same with regards to efficacy and safety. Couple minor differences here to there between the two trials, but essentially that allowed us to get that information.
I'm glad you mentioned the fact that there are other vaccines and medications out there. And it seems now to me anyway, that a lot of people are focusing on who was in the trial versus some of the medications, common medications that they're using and trusting on a daily basis, and never think about, I wonder who was in the trial for this. We just trust that the right thing was done for us in order to make sure that we're safe. And I'd like to ask a follow-up question regarding clinical trials. Is it true that those in the clinical trials have restrictions post-vaccination, for instance, not to get pregnant in 2 years?
So with all clinical trials, it's first do no harm. So we don't in clinical trials routinely enroll pregnant patients. As they are real life, real world situations, patients will get pregnant. So across these trials, not unlike other trials, we make recommendations, or the recommendations were made that 2 barrier protective methods were used if you're involved in a clinical trial. That is to protect the integrity of the trial, to protect the unknown, because we don't know until the data is gathered exactly what that safety and efficacy is going to be. So from the beginning, we're asking patients enrolled in clinical trials not to become pregnant and to make sure that their partners are aware, so that sometimes the recommendation is made for their partners to be equally protected. So there is no truth to the recommendation or the myth regarding restrictions. In the informed consenting process, patients are given information regarding the risk and the benefit, what we know and what we don't know. And I'm speaking globally for these trials, because not only are there the mRNA platform trials that we're discussing currently, but in very short order, we will see other vaccines on the market. And this pregnant patients in a study information will be applicable to all of these clinical trials for COVID-19.
Thank you, Dr. Johnson. Dr. Spates, what is monoclonal antibodies and why is it not being talked about as a treatment?
That's actually a great question. Monoclonal antibodies are really antibodies that are injected, and it pretty much mimics the body's natural immune system against the viruses. Specifically, the monoclonal antibodies that you're speaking about are against COVID-19. And they are not talked about very much because they are usually given on an outpatient basis. So it's not for patients who are hospitalized. So it is a discussion that needs to be had with the healthcare provider. So if someone is positive for COVID and they talk to their healthcare provider, they can make the decision as to whether or not a monoclonal antibody is a good option for them. The overall goal is to, again, increase the immune response so that although you have COVID, the virus, that you don't end up being hospitalized and have some of the other adverse effects associated with being hospitalized with the COVID virus.
Thank you. Dr. Kane, what are the inherent dangers to patients if their healthcare provider does not get vaccinated?
Oh, well, truth be told, he can spread the virus to his patients, his or her patients. He can spread the virus to his or her patients. Also, they can also spread it to his staff. He can become ill. Then we're without a healthcare provider if he gets ill enough that mortality is the final designated spot that as a result of that COVID infection. So I think the main thing to take from it is that if the medical provider is not vaccinated, one, he doesn't have a moral ground to stand and ask his patients to get vaccinated. Two, he or she may also wind up spreading the virus even more so than one who has been vaccinated. Even if you're vaccinated, though, there are recommendations that we still protect patients from the virus, because we can still carry the virus in our nasal passages and airways and still give it to the patient. But it's a lot less chance of that happening if he or she are vaccinated and become a moral compass to having the rest of their patients, the patient panel vaccinated.
Thank you. Dr. Moore, hopefully, yeah, you're unmuted. Should healthcare workers be concerned that their employer may mandate that all employees receive the vaccine?
Truthfully, I don't think they should be concerned with employer mandating them getting a vaccine. Now, some employers will put in place things that you will have to do if you do not get the vaccine. But putting a mandate on a person to get something, that is like being very forceful, and that will place people in the mindset of, I'm not going to get it because they want to mandate me. But I don't foresee companies saying you will have to have a vaccine.
Thank you. Dr. Spates, is it acceptable or recommended to take acetaminophen or ibuprofen an hour before or even after getting the vaccine?
So that's a lot of controversy around that. But the recommendation from the CDC at this point is that you should not pre-medicate with acetaminophen or ibuprofen prior to getting the vaccine. And the rationale is that the thought is that it can decrease your immune response. And we don't want that. If we're going to get the vaccine, we want to make sure that it's going to be effective. So we don't want anything to thwart that progress and that process. So it's recommended not to pre-medicate. However, if you have symptoms following the vaccination, you can take a Tylenol or a Motrin. A lot of people do experience soreness, especially in the arm, where the injection is placed, as well as some body aches and some fever. So you have to medicate yourself so that you still have quality of life and are comfortable. So it is okay to use after you have been vaccinated, but not before.
Having worked, thank you, Dr. Spates. Having worked in the health department, I know we used to always say that's why it's important for people to have a medical home, have someone, a doctor, that they can refer to for those questions once they leave any or are experiencing any health issues. Let's move on to COVID-19 fears. Dr. Moore, what would you say to family members who've lost loved ones to COVID-19 about why their healthcare provider is refusing to get vaccinated?
That can be kind of a difficult one to kind of wrap into one question. To say to the family members, and just being on the front line, and I want to ask Ms. Young to be a part of this conversation too, because of being in the ICU and what she sees. Just to say to the family member about a healthcare provider refusing to get the vaccine, the thing I can say to them is I'm concerned. Because when you watch a patient pass from having COVID-19, I would be very fearful of being in that position myself. So to a family member, I can say I'll be concerned. And then also the fear behind getting the vaccine is probably one of the issues that a healthcare provider is looking at. Being misinformed is another possible way to put it, is that the healthcare provider is being misinformed because it was put and placed on a political stage, and it can be scary. So Ms. Young also.
Yeah. No, Dr. Moore, I completely agree, because we've had those discussions on my unit, because when it first came out, we had a survey that we sent out to all of the team members who wanted it, who didn't want it. And I was shocked at how many of my team members were like, no, I'm not taking it right now. And I'm like, wait, what? Why? And so, you acknowledge their fears. I have a lot of young female team members. Their concerns are regarding fertility. Valid concerns. So, but you go back to the research, you go back to the data, you go back to the information and share that with them. And I think at the end of the day, going to that, the goal is to prevent the severe COVID cases that we've seen in the hospital. It's that we don't want it to get as bad as we saw it at the beginning. And we did not, in Jacksonville, we did not see it as bad as some of the places around the world and around the country. But we had plenty of hands that we held as they took their last breath. And so I think it's just going back that we want to stop that. We want to return to some form of normalcy.
So I'd like to flip that, Ms. Young, and ask you just on the opposite side, what do you say to someone who is afraid, a patient who's afraid of getting the vaccine?
I think, again, giving them information. A lot of what, like Dr. Moore said, a lot of it is misinformation. It's that they just don't know. And I can't remember who said it, I thought I wrote it down, that we take the Hep B vaccine, we take the influenza vaccine, and we haven't been asking all these questions that all of a sudden we're asking of healthcare providers and of the researchers that have gotten these vaccines on market. So it's just interesting that that fear has come around with this pandemic, and that it hasn't been there with other vaccines and other things like that. So a lot of times with my patients, we aren't seeing it right now as much. Mainly I've seen it with like my neighbors that are concerned. And so I've been like, well, what are your fears? Again, acknowledging what are your fears? What information don't you know that I can help provide for you or find for you, and help alleviate some of those fears. But it's at the end of the day, we don't want you to get COVID at the severity that we've been seeing in the hospital.
Great. You and Dr. Moore made some great points, and that is to back up to what Dr. Moore said, because the pandemic is something none of us have ever experienced, first of all. And secondly, it became so politicized. And so people are confused. I had a conversation with someone earlier who said, oh, there's just so many mixed messages out there. And I invited them to this discussion. But, that's why we're doing this panel discussion tonight and had Dr. Wells to precede us in this conversation, because we want to, as you say, acknowledge your fears, but hopefully to dispel some of the myths. Now we're going to finish with, before we open it up to the floor, with patient communication strategies, because we know that a lot of folks who are a guest on the panel tonight are healthcare workers, because that's who we were targeting. So I would like to direct this question to Dr. Moore and Dr. Kane. What should healthcare workers say to their peers when their peers say they are not in a high-risk group? So in other words, one healthcare worker to another healthcare worker, I'm not in a high-risk group, so I'm not going to get the vaccine. Save it for the people who are sicker than me. Dr. Moore, what would you say to your peer who has said, I'm not going to get that vaccine because I'm a healthy person, but on the other hand, that it might be a good idea for them to be vaccinated?
And unfortunately, we have these discussions all the time, that some say that, hey, I'm really healthy. I've never been sick in my life. I don't think I catch it. I wear my mask when I go out. But I let them know and inform them that it's not just because you're wearing a mask outside. It's whoever comes into your house can bring it to you too, and you won't know. Even the healthiest of people are the ones find themselves on a ventilator. This virus has no name, and it comes to you when you least expect it. And I told them, they asked me, why did I get the vaccine? I said, because I want to see my parents, and I have older parents. So let's not be selfish. And I talk about that. Is in order to protect other people, you have to be vaccinated yourself and do the right things. So that's kind of the peer conversation I have, especially with the folks that I work with, because we're in the front of it. We're in people's personnel mouth when they come to surgery. We get exposed directly. So this is for us to continue patient care and also protect our patients and our families.
And Dr. Moore, I'm glad you said that, because I was reminded I actually had to have surgery unexpectedly during the pandemic. And the anesthetist is who I actually thought about in the first process, but thankfully I had no issues. So thank you all. Again, Dr. Kane, is there anything you'd like to add to that in terms of having that peer-to-peer discussion with, saying that I'm healthy, I don't need the vaccine, give it to people who are more at risk?
Actually, I haven't had any peers to tell me that. I don't know if it's because they think I may go off on them or just what. So I think Dr. Moore gave an excellent answer, but I will ask them, why do they feel that way, and make sure that they understand, although 80% of the people that have died from COVID were over the age of 65, that still leaves 20% of other people under the age of 65 that can be affected. And death is not the only thing that COVID brings to the table. COVID also brings morbidity or being sick from it, and it may leave you with some very long-term consequences. Anything from myocarditis and a restrictive heart disease to restrictive lung disease, and forever affect you for the rest of your life. Not to mention what they do in terms of having the potential of passing it on to the patients and or their family members whom may be over the age, as Dr. Moore mentioned, that may be over the age of 65, and you take it home and kill your mother, your grandmother, all because you're being selfish and uh, um, uh, not taking a vaccine for no real scientific reason.
Thank you, Dr. Kane. And I know Dr. Johnson, or I think Dr. Johnson was the one that mentioned it earlier, Dr. Kane, but what do you say to patients who ask, they're getting prepared to get the vaccine, but they want to know, does it hurt? Am I going to get sick if I get that vaccine? What are you saying to your patients?
Yes, yes, it does hurt. It may hurt. You may get sick. You say, but you won't be dead. And you won't get as sick as you would if you got the virus in itself. When they start saying that they don't know what's in that vaccine, I have a guy was talking to me the other day, and he said, Dr. Kane, I don't really know what's in that vaccine. I happen to be outside doing my little curbside service. And he was drinking this Coke. I said, so what's in that Coke? And he says, what do you mean? Like something to drink and some alcohol? He's like, no, what's in the Coke? Where did it come from? When you open that can of Coke, did you know the background on that can of Coke as to what was added, what was not added, how it was made? You just trusted that the people at the Coca-Cola company was going to do the right thing for you. And so you drank that Coke. So it's the same principle as when you take this vaccine, whereby just like Coke did their research to see how much sugar they want to add to your Coca-Cola to get you addicted to drinking this Coke. We did plenty of research on in terms of background testing with this vaccine as it relates to safety.
Thank you. And lastly, and I'd like to direct this question to Ms. Young and Dr. Moore. Why is it important for healthcare workers to speak positively about the vaccine to their patients and loved ones?
I think definitely because informally or formally, healthcare workers are seen, like Dr. Wells said in her presentation, as that expert within that family unit. Just today, for example, I was speaking to one of my CNAs, and she looked at me and she's like, I had to get the vaccine because my dad was not going to get it until I got it, and he's 72. And she's like, but I wanted him to get it. I said, okay, so you wanted him to get it. You go visit him, but you weren't going to get it. And so we have to think, everybody's looking at us to see what we're doing. And if we speak positively about it, once I got my first dose and I got my second dose, I told my entire unit, I was like, this is what happened. I got a little bit of a fever and a chill. That was it. First dose, a little sore arm, and that was it. So, I made sure to show that what I'd gotten and what I had received, my mother got it. She had no symptoms, first or second dose. So, and she's 68 years old. So I think that is because everybody is looking at what we're doing. And so we have to continue to be positive about it, because that's the only way we're going to kind of deal with this, this pandemic.
Thank you. Dr. Moore?
Absolutely what Ms. Young said. When I took my first vaccination, I posted it on Facebook because I knew people followed me on there, and I posted it on Instagram. And a lot of people was asking questions immediately. How do you feel? Do you feel sick? Why did you take it? Oh my gosh, you're going to grow a third tail or something. And I had to tell them, look, I want to be able to see my parents. I want to be able to go outside without the fear of saying, hey, I didn't do my part. And that's the biggest thing in healthcare, is that we have to understand that we have to do our part. People look to us all the time. You could be a CNA to an MD, and what your words, well, as far as what you speak, your words carry a lot of weight. Mm-hmm. And in order to speak positive, you got to be positive and speak that positivity to people, and they will listen. Just as well as if you speak negativity, they will listen. Mm-hmm. So I knew for a fact, if I took it and if I showed day by day how I felt, and people are watching, then they will go do the same. And my mom talked about it to her friends, and they said, hey, we watched Nitra on, that's my nickname, Nitra. We watched her on Facebook, and we saw how she did and what she went through, and she did fine. I'm gonna go sign up. And that's the power of your words. So you have to speak positive to people out there in the community, because they doubt and they remember things back in history that they have reason to doubt. So you have to speak this into existence. You have to be positive.
Thank you. Thank you both. And I'm looking at a comment to everyone in the chat. And I hope from the discussion that we had tonight that those persons who have been skeptical about getting the vaccine remembers this comment from one of our guests. As the daughter of a nursing home resident, it makes me sad and frustrated that many staff choose not to be vaccinated. My mother requires a full-time care and does not have a choice to leave or take care of herself. She is at their mercy. She is vaccinated now, but staff members continue to be infected weekly. So I hope from the discussion that we've had so far this evening that if you were on the fence of whether or not you're going to be vaccinated, that you considered some of the comments or listen to or remember some of the discussion tonight. I know that this vaccine or this pandemic has been politicized. However, it is very real, as you heard from the panelists tonight. Hopefully we were able to dispel some of your myths, and we will open it up, and I'll go ahead and ask our trusted helpers, I won't call them helpers, students, are there any questions that have not been addressed from our panelists that were posted? If you could ask those of our panelists now.
Hi, we had a couple questions in the chat. One of them is, someone tell me that he did not get the vaccine because he has T-cell immunity. Can you address this?
He had what again?
T-cell immunity.
Now, I'll take a stab at this. I don't know the background of the story, but again, we talked about that in the what is your natural immunity versus immunity from vaccination. If you look at the medical literature in the COVID space, if you look 3 months ago or 3 months before that, this information is changing as time passes. We don't have all of the information, again, regarding sustainability of immunity. Whatever he has from maybe previous exposure to COVID-19, we don't know that exposure is going to be enough to sustain him down the road. Fair enough that we don't know how long this vaccine will last, but again, this is a definitive way to allow your body to give your body a blueprint to make something that is potentially going to decrease your chance of getting severe or critical COVID-19 disease. It's the bird in the hand. And while it is true that there are many people who will have preserved immunity from COVID-19 exposure, in terms of the sustainability of that, we don't have that data. When we have that data, we will maybe make recommendations there, but there's no body that actually is saying or recommending if you have had COVID-19 or if you've had antibodies, either from monoclonal antibody administration or from COVID-19, the disease itself, that the vaccine is not indicated. In fact, the vaccine is indicated for all of those groups. And so based on the data, I think that the only thing that I can do to respond to that question or for that person to respond to that friend is that might be the case, but we don't really have proof at this point that that is enough for the long haul.
I'll just add on to that real quick, Kim. Only thing I could possibly think this person, that if he truly had T-cell immunity, the two questions I ask, how does he know it? And have you ever had COVID before? So,
yeah, I'm suspicious that he's referring to the fact that he's been either diseased or treated with antibodies.
Right. So.
Okay, and a couple more questions that have already been addressed a little bit, but they're directed for Ms. Young, if you could expand at all. Have you had any staff members that have contracted COVID, and how have you dealt with that? As well as how are you dealing with your staff being burnt out? Are there any plans in place for them?
Okay. Yes, we have had staff members come back positive for COVID, especially at the beginning. Since the implementation of all of the PPE, we have not had any on my unit. Our organization has been wonderful. They provided goggles for each team members. Everybody has masks. They provided some at the beginning, some cloth masks that had the organization's name, Baptist Health, on it, and different things like that. But we have, for the COVID positive patients, we have the N95 or whatever the person has been fitted for, whatever kind of protected equipment they have been fitted for. So we haven't had any issues with it, thank goodness, on my unit since that. They are burnt out though. And we try to do as much as we can to help with that. I have a wonderful relationship with our neuroscience chaplain. And so if we see anybody that's kind of having a hard time, especially with a death or something like that, we definitely reach out to her, talk to that person. As an organization, they have put in place opportunities for a relax and refresh kind of room so that people can go and decompress. And they also have behavioral health specialists that are available for anybody that wants to talk to somebody. So we're trying as best as we can to keep everybody motivated. Also, there have, of course, been financial things that the organization has done for the team members, along with food and different things like that. So trying to keep everybody positive and, feeling appreciated is the most important thing, that they feel appreciated for the hard work they're doing.
And as of now, we only have one more question in the chat, and it is, what vitamins, if any, are recommended to help prevent COVID?
There are no vitamins that are recommended to prevent COVID. We do have some anecdotal data, and there are a number of hospital systems that in their hospital protocols, they're including things like zinc, vitamin C. There's some data regarding D deficiency and chronic disease that we're mapping to COVID. So the bottom line is anything that you can do to keep your immune system healthy and functional is going to help you, but it's not necessarily a guarantee that you will not get a SARS-CoV-2, nor is it a guarantee that you won't get COVID-19. But there are anecdotal, there's anecdotal experience and data that suggests that zinc, vitamin D replacement, vitamin C replacement, and I'm of Caribbean descent. So I do have no problems in using herbal therapies and other things that we have used in the herbal, more quote unquote, organic or natural space to help us to boost our immunity. But this goes back to what Dr. Wells started with and where we started this conversation. We know that chronic disease is what is additive. This is a syndemic as much as it is a pandemic. There are social factors that are contributing to this pandemic, hence the syndemic. And we need to work on those things. So if we can work on our chronic disease status, if we can work on rest and sleep and healthy opportunities and the economics of health, we know that we might find ourselves in a different place should this happen again. So anything that we can do in that space, but there's no guaranteed way to take any vitamins that will improve your chances of not getting COVID-19.
Thank you, everyone, for participating this evening. I'd like to bring the discussion. Thank you to all of our panelists, first of all, for a very lively discussion. We hope that you all have, to our guests, that you were well informed from the conversation tonight, and the Zoom was recorded, and since it was made available live on Facebook, it will be available. If you have others who were not able to join us this evening, we will be having future town hall meetings or discussions like this. If you have any suggestions on particular audiences that we should talk to, please direct your questions to the Jacksonville, or your responses to the Jacksonville Urban League Center for Advocacy and Justice. At this time, I'd like to bring Dr. Rogers Kane and Dennis Stone back to give our closing remarks.
Okay, as Ms. Turner has alluded to, I really want to thank everyone for attending this informative event, town hall meeting. We're really trying to educate our healthcare providers, anyone that's a healthcare of any type healthcare provider. Really want them to go back and talk to their family, have a discussion, informed discussion with the family members as to why they should take the vaccine. And most of all, I want to thank these very brilliant young ladies that are on this panel that just run circles around me in terms of their intelligence and how much I appreciate that they were ready, willing, and able to participate in performing this, being on this panel at the drop of a dime. And some of them we got at the last minute, and they just dropped everything they did and stepped up to the plate and did everything that was required of them to provide information to the audience at large. So thank you guys very much. We want to appreciate the Urban League and the other partners, NAACP, Florida A&M University, and obviously the Northeast Florida Medical Society and the First Coast Black Nurses Association for taking the time out and assisting us with this presentation. With that, I'm going to leave it up to Dennis to close out.
Once again, I wanted to thank everyone, as Dr. Kane did, all of our partners in the African American community who've come together. I particularly want to thank them because it's helped us in a number of ways to address other issues that are tangential to health and some of them not so related to health, but affect the communities we serve. And so we just want to thank you for that. Catalyst, the catalytical effect that you've had on our services. I did want to point out that tomorrow night we have a town hall, same time, same station, that focuses on the city's response to community engagement and providing funding for their budget, which obviously includes health issues. So we encourage all of you to attend. We will send a link out to everyone who attended this event, and we will also be sending you a survey asking you for some feedback and suggestions for other town halls. So please pay attention for that. And then finally, I just want to thank all of our wonderful interns who've been helping with this and our other events. And particularly our new ones this spring, who've been so helpful in a number of areas. And finally, the staff and team at the Urban League and its members have been so helpful for making events like this happen. So thank you again. And as they say in COVID era, be safe.
Thank you. And not sorry.
Thank you. Good night.
Good night.
Good night, everyone.